Great.
Okay, so it's my pleasure to introduce Dr. Salas. Dr. Salas obtained his degree in medicine in 1996 from McMaster University. He completed his postgraduate training in neurology at McGill University in 2001, followed by a clinical research fellowship in behavioral neurology and stroke at the University of Toronto under the mentorship of Dr. Sandra Black. He joined the Division of Neurology at Sunnybrook Health Sciences Center in 2003 and served as director of the North and East GTA Regional Stroke Prevention Clinic from 2003 to 2008. In March 2008, he took a position at McMaster University, joining the Division of Neurology at the Hamilton General Hospital, which is the regional stroke center for Central South Ontario. In July 2008, he became the inaugural recipient of the M.G. de Groot Professorship in Stroke Management and also began a 5-year term as champion best practices across the continuum of care for the Provincial Coordinating Council of the Ontario Stroke Network, which is the governance body for the Ontario Stroke System. In January 2014, Dr. Salas assumed the responsibilities of Program Director for the Adult Neurology Residency Program and Fellowships at McMaster University. In 2021, he was recognized for his contributions by receiving the Department of Medicine Postgraduate Education Award, as well as the Undergraduate Education Award. In July 2022, he was promoted to full professor and assumed responsibilities as both Division Director for Neurology and Clinical Head of Service for Neurology at Hamilton Health Sciences. And with that, I'll turn it over to Dr. Salas.
Thanks. My whole life flashed before my eyes as you're saying that. So I don't know if anyone has heard me speak before on this subject. Has anyone heard of similar rounds in the past I'm just looking at the attendees here. In case there's any repetition. Okay, well, if not, I have shared a copy of the slides with Tina and Rhonda. It's a 16 megabyte file because there's some images, so it might fill up your inbox if you get a copy, but I'm happy to share it. So our objectives for today are to discuss the pathophysiology of carotid artery disease, to review the medical and surgical management options, and then to describe a systems approach to symptomatic disease. I'm not sure where people are practicing. I think it's important for me to try to, I guess, do people want to ask questions during the talk, like put up their hands, or do you want me to finish the talk first and then and then answer questions at the end? We could do it either way.
Well, I can monitor the chat, and if people
Okay,
do put up their hand or write something in, I can alert you.
sounds great. Okay, thanks, Tina. Okay, so all of you are familiar with the pathophysiology of the atheromas that develop in our carotid arteries. It's so important to convey to patients when we talk about narrowing of the arteries that it's not the same paradigm as a cardiac or coronary artery where, you know, there's demand ischemia and then exertional angina. Narrowing in the carotid arteries is a risk because these plaques sit there for many, many years, not really causing any problems. And then one day, a sizable plaque might rupture. As soon as that happens, thrombi begin to form, and then the plaque is a source of thromboembolism to the brain. So I find it's very helpful to explain to patients that our approach is to optimize vascular health to promote regression of these plaques when they're not symptomatic. When they become symptomatic, we want to remove them, not to restore flow, but to remove the thromboembolic potential. So that's key. And here you have a little diagram of a ruptured plaque with pieces of thrombus going up into the ICA. So our evidence to support carotid revascularization is quite old at this point. The NASA trial was performed in the 90s. And even back then, it identified a heavily front-loaded risk of stroke. So again, these plaques sit there for many years. an asymptomatic plaque, it's 1 to 2% chance per year that someone may have an ipsilateral event. If you're on maximal medical therapy, it's probably 1% or less. But then if it ruptures and you experience a TIA, the risk of a subsequent stroke can be as high as 5.5% within 48 hours and 20% according to NASA within 90 days, much of that in the first couple of weeks. Now, in terms of how we measure the percent stenosis, it's important to ask your radiologist to use the NASIT criteria, where the narrowest part of the lumen is measured, that's the small d, and as the denominator, you use the distal normal diameter lumen. And so that gives you a percent stenosis. The ECST study did something different. They measured the minimal lumen and then kind of guessed what the lumen should be, and that created lots of variability. And so we don't really use that method. It's interesting to realize that when we talk of a 50% stenosis by NASA criteria, it translates into a 75% stenosis of the cross-sectional area of the artery. A 70% stenosis by NASA criteria is a 91% stenosis by cross-sectional area. And a 90% stenosis is a 99%. So you're probably asking, how can this be? The reason is that when plaques form, they are crescenteric. So what you end up getting is the plaque encroaching around, and you're getting a shrinking lumen. So even if you have a 50% stenosis, it's not just like half the lumen is plaque and half is not. It's actually crescenteric. So you actually have shrinkage of the lumen even above and below the area of stenosis. So we found in the NASA trial, the European trial, ECST, and the veterans trial, that carotid endarterectomy was beneficial for patients with high-grade stenosis. The number needed to treat if you underwent carotid endarterectomy anytime within 6 months of the event was on average 8. For a moderate stenosis, according to those trials, it didn't seem to be as beneficial. The number needed to treat was 22. And so for many years, we didn't really feel that carotid endarterectomy for moderate stenosis was helpful. This is my pictograph of what's involved. You explain to a patient that an incision is made in the artery, the plaque is removed, and then the artery is sewn shut. We actually have a carotid endarterectomy booklet in our stroke prevention clinic, which explains everything, and we just hand it to the patients if they're being considered for surgery. And that's what a plaque looks like when you remove it. So what's important to note is that in terms of the risk and the front-loaded nature of the risk, one moment. Because the risk is front-loaded, the benefit is higher earlier after the index clinical event. So if you can get to a symptomatic carotid artery within 2 weeks of the event, the absolute risk reduction for a severe stenosis is 30%. A 30% absolute risk reduction translates into a number needed to treat of only 3. In other words, if you have a patient present to the emergency room with a symptomatic high-grade stenosis, you only have to operate on 3 people to prevent 1 stroke within 2 weeks. Thinking about it another way, 1 in 3 of those patients will have a stroke unless you do surgery. If you don't get to those patients within 2 weeks, those that are likely to have their stroke, get admitted to rehab, and you don't see them. And so 2 to 4 weeks, the benefit is less because people that were going to have a stroke if nothing was done have had the stroke, and you're dealing with a group where the risk is now lower. So the absolute risk reduction is 17% for a number needed to treat of 6. And it keeps going down over time. By 4 to 12 weeks, your number needed to treat is 9. So the absolute risk reduction keeps going down and the number needed to treat goes up. And by greater than 12 weeks, or more specifically, from 3 to 6 months, your number to treat is 11. So if you're only getting to patients to have them undergo carotid endarterectomy after 2 weeks, people are unnecessarily having strokes. We don't want to get to people down the road. It means we're dealing with the survivors. And after 6 months, the ruptured plaque is considered healed. So we typically regard a ruptured plaque as asymptomatic again at the 6-month mark. And the reason is because the original trials were done within 6 months of the event. Those are the dark gray bars. The light gray bars show you the absolute risk reduction for a moderate stenosis. Now, you remember that we talked about a number needed to treat of 22 if you're looking on average over the course of the whole 6 months. But if you can get to even a moderate stenosis within 2 weeks, then the number needed to treat is 7, because again, it's a front-loaded risk. It's worth sending people for carotid revascularization with a moderate stenosis, 50 to 69%, if you're getting to them early. Another way to think about it is if you see 7 patients with a moderate stenosis that's symptomatic in the emergency room, 1 in 7 or 8 of them are going to have a stroke in the next 2 weeks unless you do something. After 2 weeks, the risk is really down for the moderate stenosis. The benefit is really not there. So we don't typically send people for a moderate stenosis for surgery after the 2-week point. If you look at all patients with a 50+% stenosis on day 1, the moderates and the severes combined, your number to treat is 5. So we like to think of them as a group within the first 2 weeks, and then only deal with the severe stenosis after 2 weeks. This is a table that just states that in a different way. For this and other things, I really emphasize referring to the Canadian Stroke Best Practice Recommendations website, which is frequently updated and has all kinds of citations and what's considered best practice. So not just for carotid revascularization, but for anything stroke related. Here's a screenshot. Please type in Canadian Stroke Best Practice Recommendations and familiarize yourself with the website. It's really useful, and like I said, it's frequently updated. And so just reiterating from the best practice recommendations, in men with 50 to 99% stenosis and women with 70 to 99% stenosis, carotid endarterectomy is recommended to be performed as soon as possible following the qualifying event. What does as soon as possible mean? In our institution, we consider that within 48 hours of the neurologist or stroke physician and the surgeon agreeing that the surgery needs to be done. Not necessarily within 48 hours of the actual event. Things are very unstable within the first day or 2, and we actually identified a little bit of an increase in complication rates when we were operating on day 1 or 2. So the sweet spot seems to be day 3, 4, 5 to get in there without complications and prevent a stroke. You might ask, why men and not women? What's the difference? There's many ideas about this. One possibility that I think makes sense is that, it's not really very much gender based. It might also just be size of the carotid arteries based. In general, men have a carotid artery about 5 millimeters, give or take, women 4 millimeters, give or take. And so the same size plaque in someone with a larger artery versus a smaller artery will cause a greater stenosis in the person with the smaller artery. So a plaque that would cause a moderate stenosis in someone with a large carotid artery, most men, would cause a severe stenosis in someone with a smaller carotid artery. So I know that's a little complex, but basically, if we're looking at the thromboembolic potential, it's really the size of the plaque, not the degree of stenosis, that we worry about the most. Having said that, we still consider carotid endarterectomy in many women with a moderate stenosis. In terms of surgery versus stenting, the best practice recommendations state that surgery is generally more appropriate than stenting in people over the age of 70 who are otherwise fit for surgery. That's the official word. They're both options. Realistically, the surgeons are very nimble and can get people in and out very quickly. I think in terms of stenting, there's some resource challenges in terms of access to the rooms, and the interventionalists are doing many other things. So I think we really favor stenting for 5 indications, and here they are. Patients with a high carotid bifurcation where the surgeon may not be able to get to the ICA because it splits into the ICA and CCA above the jawline. So surgeons won't be able to access that. So that's a good candidate for stenting. People who have had radiation-induced ICA stenosis, the arteries are kind of friable and stenting is better rather than surgery. If they've had a previous surgery or stenting, if there's a contralateral occlusion, flow is easier to continue during stenting versus surgery, although it's still possible to do surgery on someone with the contralateral occlusion, but it's often regarded as a valid reason to think about stenting instead. And people who are not medically fit to undergo general anesthesia. Those are the 5 generally accepted reasons for stenting over surgery. In terms of asymptomatic disease, there's you need to have a really good reason to operate on somebody with asymptomatic stenosis. In general, we don't consider it. It's certainly not favorable to medical therapy. Here's the catch, though. If you can optimize someone's vascular health through medications, smoking cessation, and so forth, that's the preferred route. Really, surgery shouldn't be considered in those cases, especially with the advancements in medical therapy with statins and so forth. Statins weren't widespread when the original trials were done. If someone isn't compliant with medication, or if they won't stop smoking because they can't, surgery really becomes an option for asymptomatic disease. Remember, we think that optimal medical therapy is preferable to surgery, but if you can't establish optimal medical therapy, surgery becomes an option. That's the way to think about it. So a few cases of patients with asymptomatic stenosis, should be considered for surgery. It's a case-by-case basis. Now, what about asymptomatic disease with a moderate or high-grade stenosis? Is aspirin enough? Well, like for secondary prevention, for many years, we thought that aspirin, not even a primary prevention. So here's a key thing. Let's suppose somebody has hypertension, diabetes, and have never had a TIA. You're not going to put them on aspirin. Antiplatelets are our second line of defense. They should be implemented for secondary prevention. But if somebody has a coronary event or problems in another vascular bed, and they also have carotid artery disease, aspirin alone seems to be inferior to aspirin plus low-dose rivaroxaban from the COMPASS study. So there are many patients that we see in the stroke prevention clinic for asymptomatic disease that turn out to have had coronary artery disease in the past and have moderate to high-grade asymptomatic stenosis. These are people that we would, if they haven't already been started on low-dose rivaroxaban in addition to aspirin, these are people that we would add the low-dose rivaroxaban to. In terms of the timing of surgery, we talked about how it's important to get to patients as soon as possible. In the best practice recommendations, we talk about ideally within 14 days for people with the high grade, and basically not for moderate stenosis after that. In terms of imaging, CT angiography is important to see what's happening below and above the carotid artery disease, whereas carotid ultrasound can identify very reliably the degree of stenosis if it's interpreted correctly. That's sometimes an issue. It doesn't show you access points below for stenting, or what the circular Willis looks like. You may be dealing with what's called a suspended hemisphere with an incomplete circle of Willis, and that would render an increased risk to carotid revascularization. So we like to do both carotid ultrasound and CT angiography if we're actually considering intervention. Carotid ultrasound is very helpful because it's a dynamic modality. It's not as prone to artifact from calcified imaging, and it's usually complementary to CT angiography. People sometimes regard CT angiography as the gold standard. It's not. Conventional angiography is the gold standard. When you try to measure the size of a lumen on CTA, don't forget it's a digital image and it pixelates as you zoom. It's really hard to know where to place the caliper. Also, the vessels can be very tortuous, and if there's calcium in the wall, you can't really see. There's shadowing artifact from that, so that renders it harder to measure as well. Here's an example of a CT angiogram that's very hard to determine the degree of stenosis with the amount of calcium there. And then you see the tortuosity. They're actually making these, it's not a straight line to the skull. There's actually a very big S-shaped curve. This is just an example of how it's possible for CT angiography to be qualitative as well. There was a report of a CT angiogram stating marked bilateral proximal IC stenosis, 85% on the right and 90% on the left. So then we did an ultrasound on that person, and on the ultrasound, we saw that it's actually much more likely to be greater than 70% on the one side, but less than 50% on the other. And then we showed this to the radiologists. They revised their CT angiography report to say, oh, actually 48% on the left and 85% on the right. So if you get a CTA report that gives you these percentages, don't treat them as gospel. It's important to have another look with an ultrasound. And then if they're agreeing, then you move forward. If there's a disparity, you have to look at one or the other and see why there's the disparity. So here's the slide that I like to show our trainees. From carpentry, you think, you measure twice, cut once. So measure twice with CT angiography and carotid ultrasound, and then just cut once. In terms of the diagnostic criteria for ultrasound, here's where people run into pitfalls. The actual ratio is ignored by a lot of people interpreting ultrasound in the community. So you can see that peak systolic velocity of, and these are actually all, they've upped the criteria for the peak systolic velocity for the greater than 50% now because of people's lack of use of the ratio. If you have a peak systolic velocity in your ICA of 125 to 230 centimeters per second, that could be a moderate stenosis, but only if the ratio of the velocity in the ICA to the CCA is greater than 2. Very often you see people calling a 50% stenosis when the velocity might be 200, but the ratio was 1.5. They both have to be meeting criteria to really call it 50 to 60. And likewise, for the ICA of velocity of greater than 230, that's typically high grade or greater than 70%, but the ratio has to be greater than 4 as well. So I think it's important to share with you to just glance at the Lindegard ratio, the ICA ratio, if there's any ultrasounds that have been reported. You need a ratio of 2 to 4 for it to truly be a 50 to 69% stenosis. You need a ratio of greater than 4 for it to truly be a 70% stenosis. So here's an example of what an ultrasound looks like. This is with power Doppler. And going into this area of stenosis, you can see what's called a tardus parvis waveform with a very slow systolic upstroke and a delayed diastolic downslope. And then here you see the increase in the velocity in the middle of the stenosis. So this is 642 centimeters per second, far greater than the 230 that you need for greater than 70%. And then afterwards, you see that there's like a very tiny flow afterwards. We should talk a little bit about near occlusion. So that's a state that an ICA can attain when you have a severe stenosis that's so bad that the volume of flow has markedly diminished, and then the caliber of the lumen actually begins to shrink. So your velocities actually increase up to a certain point, then past 95, 99% stenosis, there's actually a problem with flow and your velocities drop again. And there's CTA criteria and ultrasound criteria for this. The reason I mention this is that it's a bit controversial whether or not patients with near occlusion should undergo carotid revascularization. You would think, oh my gosh, well, severe stenosis is worse than moderate stenosis, and near occlusion is worse than severe. It's like a category of severe stenosis that's like the worst. So obviously the risk must be higher and the benefit greater for near occlusion. In fact, because the volume of flow decreases and the lumen is collapsing, the thromboembolism risk is less. So in fact, once you get to near occlusion, the risk begins to go down and of a stroke, and the risk of a complication of surgery begins to go up. So in Europe, they don't really operate on near occlusions. And in the United States, they operate on everything. So they operate on near occlusions as well. And in Canada, as you would expect, like sometimes we do and sometimes we don't operate on near occlusions. Just out of interest, one of our fellows did a study, one of our stroke fellows did a study where they looked at every CT angiogram that was performed at the Hamilton General between 2013 and 2014, a period of 18 months. There were 700 CT angiograms. Now, there was almost 70 or 10% of patients that had a CT angiogram had a near occlusion on one side or the other, or both, 10%. So that's how common near occlusion is. And out of those 68 patients, 39 of them had recently been symptomatic. So you want to ask, well, what happened to those patients with symptomatic near occlusions? Because we have an inconsistent approach to them, 18 were treated medically, so they did not get surgery, and 21 underwent surgery or stenting, some of them repeated. Interestingly, again, this is retrospective and not case controlled or anything, but in the medical group that didn't get surgery, the median modified Rankin score at follow-up 2 years later was 2. So that's not severely disabling. And 3 patients actually suffered an ipsilateral stroke. In the surgical group, there was no difference in the modified Rankin score, and 3 patients suffered an ipsilateral stroke. In addition, 3 others were readmitted to hospital within 30 days of the intervention due to procedural complications like MI, sepsis, and so forth. So just looking at our own center, very checkered with respect to outcomes in terms of near occlusions. Whether you operate or not may not make a difference, and if you do operate, there is a higher risk of complications. So near occlusions need to be considered very carefully. So I think what I want to do in the systems portion is to talk to you a little bit about the wait times for carotid endarterectomy in Ontario. And we can start by talking about what was the state of affairs back in 2003 to 2006. So how did we get at wait times for surgery back then? So just looking at patients admitted to regional stroke centers like Hamilton and Sunnybrook and elsewhere, there were 105 patients admitted for surgery. Clearly, many more carotid surgeries were being done, but 105 patients were admitted to a regional stroke center for symptomatic 50 to 99% stenosis. So we pulled this from the stroke registry, and it was a median time from the index event to surgery of 30 days, and only about a third of patients actually got their intervention within 2 weeks. Now, there was an improvement noted over the 2 to 3 years of establishment of the stroke system, but that's not too good. In terms of regional experiences, in London, 2006, 2007, they published their experience. Their median time from the last neurological event to the surgery was 83 days, and only 4% of patients were getting surgery within two weeks. Lots of room for improvement. And in Ottawa, they also published their experience between 2008 and 2010. Their median time was also almost 3 months. Again, lots of room for improvement. So we did our own study here in Hamilton after this SPC audit was released. So the stroke prevention clinic audit didn't look at patients admitted to a regional stroke center. It looked at patients that underwent surgery in the province, right? So actually in that 1 year, 1,414 patients underwent carotid surgery in Ontario, but only 16.6% were seen in a stroke prevention clinic. 85% of people getting carotid surgery were not seen in a stroke prevention clinic. Even those that were seen in the stroke prevention clinic, the median time from the first visit to the surgery was 28 days, a month. The median time from the index TIA to the surgery was like almost 2 months. Lots of room for improvement, lots and lots of room for improvement. On top of that, there were readmission rates among patients who had a TIA following a stroke prevention clinic visit. Now, this is actually following a stroke prevention clinic referral. So there was 1.8% people coming back to hospital within 30 days and 2.9 within 90 days, 2/3 of the time before their first clinic visit. So I think, so basically we needed to get faster. So in Hamilton, what we tried to do is we first tried to get information about each patient going for carotid revascularization. So we had this report card that was based on our TPA report card that Rhonda remembers well, having developed it. And we put the data of the index TIA, the data of the initial medical evaluation, the data of the referral to stroke prevention clinic or neurology, when they got their carotid imaging, when they were seen in the stroke prevention clinic, when they were referred for surgical assessment, and when they were intervened. So we had benchmarks and achievements. And so what did we find in 2012? We had 43 patients go for surgery in 2012. But even here, only 24 of those patients were seen in the stroke prevention clinic. Almost half of them were referred directly to a vascular surgeon or a neurosurgeon. So we said, okay, well, half are going to the stroke prevention clinic and half are they're skipping the stroke prevention clinic and going straight to the surgeon. You would think maybe that's faster. In fact, the mean time from the index clinical event to surgery was 28 days for those referred to the stroke prevention clinic. And a third of them were able to get the surgery within 2 weeks, better than anything we've seen anywhere else up until now. Still not great. The mean time from the index clinical event to surgery was 53 days when they were referred to a surgeon. So, I mean, you're all hospitalists. I mean, definitely if somebody has a TIA, it's slower to refer to a surgeon. It's faster to refer to stroke prevention clinic. Usually, certainly in our jurisdiction, maybe you have local variances, but certainly here, it would take time to see the surgeon. It would take time to book the elective procedure. And then much of the delay was also related to obtaining the carotid imaging. So up front, people were trying to get the carotid imaging first and then refer to the stroke prevention clinic. So we made lots of changes to try to address these big discrepancies. And again, here you see a bar graph, and it's statistically significantly different. The delay in surgery in those referred to the clinic doesn't take long to be funneled to the surgeon versus people who, quote, skip the clinic and go straight to the surgeon ends up taking longer. So we met with the surgeons, and I think we benefit from a wonderful relationship between neurology and vascular surgery here. And there was agreement from the surgeons to just redirect all referrals to the stroke prevention clinic. So even this morning, I was speaking to one of the vascular surgeons, and he's like, look, if I get a referral for carotid endarterectomy, I will just send it straight to you guys. And I don't care which of my colleagues sees it. Like, it's not my patient. So if on Monday I get the referral and I just send it along to you. By Tuesday or Wednesday, you'll have seen the patient. By Thursday or Friday, the patient will have already had their carotid endarterectomy, maybe by myself, maybe by one of my colleagues. So the surgeons were all in. And what helped is that they were willing, the vascular surgeon on call would see the patient in the actual clinic. In terms of the carotid ultrasounds, we just tell family doctors, do not bother with a workup. If your patient has a TIA, send them to our clinic. We'll see them within a day or two. And at the clinic, if they haven't yet had carotid imaging, we'll organize it at the hospital. So they set aside some slots for us in radiology. We send them down, they have their carotid ultrasound. If it's fine, they go home. If it's not, they come back. We organize a CT angiogram and we contact the surgeon and they get admitted that day. Again, we talked about a time frame of 48 hours to getting the patient done after the neurologist and the surgeon have agreed it needs to be done. So basically, that helps the surgeons get the case done. And we've developed these regional referral algorithms to access both inpatient and outpatients. So and this is what we saw. So our median time from the index clinical event to the surgery had plummeted. So last time we looked at this, it's just pretty much just a straight line down to the bottom now. But the last time we looked at this in 2017 to 2018, we were getting 75% of patients were getting their surgery within 10 days of the event. And 90% were getting it within 20 days of the event. And so the critical elements here is that bypassing a stroke prevention clinic, certainly in our region, leads to significant delays. So we engaged with surgeons and interventionalists to agree that the SPC would be the initial central intake. To the point that if a surgeon is referred a case, they just pass it along to us and we'll see the patient quickly. The surgeons love this. Like again, the surgeon I was talking to who's been practicing for 30 years this morning said, I am not a neurologist. Like, just, tell me which patients to operate on, right? I don't want to sort through them all. I don't want, and I certainly don't want to operate on somebody that a neurologist then says, you shouldn't have operated on that person, right? So we protect our colleagues as well by saying, yep, this needs to happen. Nobody can come back afterwards and say that it shouldn't have been done. You've got us on board. And we also make sure that family doctors know not to work TIA patients up themselves. That's what the stroke prevention clinic is for. Family doctors are busy enough. They don't have to start juggling all like brain imaging and carotid imaging. Just send the patient to us, we'll deal with it. Close relationship with radiology is obviously very critical to expedite all these investigations. And this would not be possible without strong administrative leadership. So it doesn't matter what the physicians and surgeons want to do. If your administration is not supportive, it's not going to happen. If your administration feels it's important, it happens. And so I think we have really been blessed with strong administrative leadership in that regard. So I just usually wrap up the talk speaking to people about our regional stroke prevention clinic. We do the intakes in the mornings in case we find a symptomatic carotid. We want to be dealing with that starting at 3 p.m. So we only do new patients in the mornings. 2 neurologists are seeing 8 to 10 patients. There's usually 1 or 2 trainees and a nurse who actually sees all the patients and meets with them and takes their blood pressure and gets down their medications. And as I mentioned, same-day carotid ultrasound imaging with MRI or CTA is required. Our follow-ups are in the afternoon, so we're not dealing with new hot cases in the afternoons. And then Friday night weekend referrals are, in the past, before the pandemic, we had the ability for the Emerge to book directly into our clinic. We haven't really gone live with that again. Just as an interesting anecdote, Tuesdays after a long weekend were always crazy. We often would bring on a third physician to see like 15 patients, but we have room problems. And then one of our vice presidents, the VP of Adult Regional Care, showed up at one of the safety huddles one morning and said, "Why don't you guys see people on the weekend?" And I'm like, "Sure, sign me up." So on statutory holidays now, we did it first on Thanksgiving, and I'm doing it again this coming Monday, which is a hospital stat day. We're bringing in a nurse, a clerk, and a physician just to keep the pile from getting too big. And we're going to see 5 or 6 patients and just keep a timely timeline there. Okay, I'm actually going to stop because there are some cases here, but I don't think they really... they just kind of emphasize what I've already discussed. And I really think it's important to be interactive. I've been talking for about 40 minutes. So I'm sure there's going to be questions. So I'll open it up for questions. If I should first start, ask Steph. Steph, do you think that did I miss anything?
No, I think that was great, Jim. I appreciate it. It was a wonderful presentation. A lot of really key points within there. And I think, part of the element that you highlighted is really that collaborative approach to this. And it's not one person at a site that really drives this. It's a whole team approach and different specializations and different colleagues all getting together to make it work. So no, I think you did a great job. Thank you, Dr. Salas.
I'm interested to hear from people about their local challenges.
Yeah, so if you would like to raise your hand and do it verbally, please do. There's also the chat function if that's a preference.
Where are people from? Maybe just to get people talking, we could ask people to, I mean, I don't know if it's the second uh, video conference, we could ask people to unmute, maybe even turn on their camera and share with us where they're from. I should have done that at the beginning, but anyway. Hello.
Hi, Jim. It's Charmaine. I just had a question on how to deal with the issue around radiology had sent out a memo saying that they were no longer going to do carotid ultrasounds on patients who've already had CTAs. If we had concerns about like significant symptomatic stenosis, because they said the CTAs are gold standard. And we know that one is a static image and one is a dynamic image. I'm just not sure how do we relay some of this information or this concepts back to our radiology departments, because we order them and we give our rationale why we need them, and we'll still get them canceled by radiology. And so I'm just not sure how to deal with that issue.
Yeah, I mean, I would love to tackle that offline with you. I think I can see the radiology perspective. They're probably trying to manage resources in the hospital. They're seeing this as an unnecessary duplicate. I showed you guys a good example of a CTA that, they changed the report based on the ultrasound, right?
I know.
So we need to acknowledge that CTA is not the gold standard, and we feel most comfortable moving forward. I think you need to engage with radiology so that they understand the rationale. I would hope that they're reporting using NASA criteria. That's another thing. Are they even reporting using NASA criteria? I don't know. But that sounds like I would love to dive in. Let's talk after, and anything I can do to assist. It could be that you're going to need to get your. I can tell you, there's lots of vascular surgeons that would be happy to provide their ultrasound laboratory as the place that patients get their carotids done.
Yeah, I know. We have an ultrasound tech that comes into our stroke prevention clinic once or twice a week, who's quite good, Chris. And we get it done, but then it's not reported into the mainframe because it's a private clinic, which then creates discrepancies online with the medical records, right? About what the results are. I think, is there criteria, like, how you had lots of calcification, right, that interfered? Is there certain criteria that we could say, well, based on X, Y, and Z, like they had lots of calcification, et cetera, that this would be the rationale why we would want the ultrasound? Or
yeah, I mean, I think tortuosity would be one factor. Calcification, heavy calcification would be another. And ultimately, I think pushback could also be, I mean, they're not the surgeon, right? So if your surgeons don't feel comfortable operating, or if the physicians don't feel comfortable recommending, and they say, look, I require a carotid ultrasound in order to provide an opinion, then they're kind of stuck. They can't say, well, we don't think it's necessary. It's like, well, I need it, right? So again, we can take it offline, but I think
I think it's a worthy conversation to have, even with our chief of our service, about that decision, because there are not every patient by any stretch, but there are patients we have to be able to say, just like when we talk about carotid endart versus carotid stenting, there's criteria that we choose patients for that. I just would love to think of some specific criteria that would be the standard.
Yeah.
Yeah.
Yeah. I saw Dr. Ahmed there from Brantford with, I think there's 3 hospitalists from Brantford.
Yep.
Yeah. So there's actually an interesting case just recently where I was speaking again to this surgeon this morning about a patient who was seen in the emergency room at Brantford and then referred directly to the surgeon. And I said, why did they do that? And then the surgeon said, well, they told me that they spoke with the stroke prevention clinic first, and the SPC told them just speak directly to the surgeon. So I think we have to touch base with the SPC there. Again, I think surgeons do feel better once. Again, the surgeons that are operating on the patients from Brantford are the surgeons here. So and it's important to kind of address that as well. Any unique challenges in this regard in Brantford, or?
I mean, I guess one of the things I think about is whether, so we do have our local secondary stroke prevention clinic. I don't believe our internist for that, Dr. Pastuszewska, is here today. So I wonder if she was the one that the emerge doc spoke to. But sometimes I'm not sure whether to send to our local secondary stroke prevention clinic or send to your secondary stroke prevention clinic. And it feels like you've got quicker access now that I see your hours. That's very impressive. And I commend you for agreeing to work on holiday weekends. That's very committed of you. But to me, so I always feel like local is better, but I actually think in terms of access, it might be better to just refer to your clinic.
Yeah, it's interesting because we have a relationship with the Stroke Prevention Clinic in Brantford where when patients are seen, patients referred to the SPC in Brantford who are seen and are judged to be candidates for carotid surgery, those patients get referred to our Stroke Prevention Clinic. So the pathway is, they're seeing somebody in the SPC, they get referred to our. So I think people in the emergency room, I don't know, something we need to look at.
I think we need to look at that.
Yeah.
It's sounding a little bit. It sounds like there may be some redundancy, and we could do a more direct.
Yeah, we almost skipped 2 steps there, right? So if their normal process is SPC in Brantford, SPC in Hamilton, surgeon, it was emerge to surgeon. So I think we,
Right.
maybe emerge to SPC in Hamilton. We have to talk about it, but yeah. The other thing is on the weekends, the SPC typically it's like Monday to Friday. So on the weekends, it's possible to speak to the stroke physician on call in Hamilton.
Yes.
And then kind of discuss about what needs to be done. The key thing as well is TIAs versus strokes. So in Hamilton, because we're always in gridlock, to help with that situation, we tell the emerge never admit a patient with a TIA. One of the things that will slow the whole process down is if they get admitted to medicine, frankly. So I think it's important for the internal medicine residents to see these patients, to get some familiarity with them, because they'll be working in jurisdictions where they might see them. But the reality is a TIA patient who the emerge doc is really concerned needs to be seen really quickly. They hang on to them, they keep them. Medicine admits them, a day or two later. Like it's actually slower. If they get discharged and seen the next morning in the stroke prevention clinic, then they get all of their imaging done faster than if they were in the hospital, and they're seeing the surgeon and getting booked for the OR 24 hours later. It's actually faster. So for TIAs, we tell them do not admit them. That's the slower pathway. But for actual strokes, we tell them never discharge them. So anyone with a stroke, no matter how small, needs to stay. And the reason is, as physicians, we can do a neurological examination, but we are not expert at determining the functional impact of a brain injury. That's what physiotherapists and occupational therapists and speech language pathologists do. So the stroke prevention clinic, it's not a stroke clinic. It's not for patients. Oh, they've got a minor stroke. They don't need to be admitted. They could just be seen in the stroke prevention clinic. Wrong. These patients, when we see them, we just admit them to the floor. They basically delayed their inpatient stay by an entire day. So we don't have therapists. We don't have allied in the stroke prevention clinic. We can't gauge the impact of a deficit in the. You need to be admitted to a stroke unit with the comprehensive approach, with medicine and allied and nursing. Yeah. That's what people need when they've had brain damage, vascular brain damage, and it's some people seem like, oh, it's just a minor stroke. Well, many professions, our own included, like any kind of small stroke is going to impact it. Yeah. What do you true. Like we've had lots of people that are young and working, and they come into the emergency room with a stroke, and they're like, "Ah, you're walking, talking, you're fine." Well, they're not going to work the next day. So then what do? They're sitting at home wondering what happened, you know? So they
Yeah.
get lost. So then they
We,
get
we do get a fair number of admissions that are, either high risk TIA or TIA rule out stroke.
Yeah.
Like that gets admitted quite a bit. And I see my colleague, Dr. Grabner's asking, what about high risk TIAs? So there is a bit of gray, I think.
Yeah.
But
I mean,
it's a helpful summary to know about where, what's the quickest way to access what they need. So that's a good summary.
exactly. Yeah. And I think a TIA rule out stroke would be for persistent symptoms. So I'm happy you raised that point. If the brain imaging is negative, but the person still has symptoms, they don't leave the emerge. So again, in terms of gray, emerge docs tell me they hate gray. They want black and white. So I'll give you an easy rule, right? If the person's back to baseline and the imaging is negative, stroke prevention clinic. We'll see them the next day. It's faster. Here, you might need to admit people that are high risk because it might be faster there. Like every center has its own pathways, right? If the person has persistent deficits or a stroke on imaging, you admit them. So it's just black and white. Like they love it. They just go, just tell us, and they don't have to think about it. They got 20 other patients to deal with. So yeah.
That's great. Thank you.
Yeah. So I think I'm glad I kind of stopped the presentation and didn't go through the cases because I think discussion is really important.
Okay. And just to note that there's in the chat, Rayanne is an NP with the CAT team here at the General. So she's introduced herself.
Oh, wonderful. Hi. What is the CCATT at
Rayanne, are you able? Yep, there you are.
Hi, everyone. The CAT team. So focus on emission avoidance.
Yes.
Usually for high frailty patients, but I am actually glad you went over the TIA versus stroke and discharge versus admission, because all the time in Express, we do see patients who have stayed overnight and are admitted to medicine with TIA. So now I can advocate for a referral to stroke prevention clinic, and let's get them out the door and get them to see you guys. So
well, actually, once they're in, we're stuck because then it's slower. So here's the thing: we want it at source, right? So if they're a TIA, they need to go. If the mistake is made and they're admitted, we're committed, because now if they're admitted to hospital, they need to be seen by the stroke consult service. And so in other words, if they came in on Monday and now Tuesday is their day for their stroke evaluation, if they were discharged, they're being seen in a stroke prevention clinic. If they were admitted, now they're seeing in hospital. If we then discharge them, then they get seen another, like it delays everything. So
that's not helpful for those 11 p.m. admissions with the resident, and CAT is consulted for 7 a.m. to see because they're already admitted at that point.
Once they're admitted, that's the problem.
Okay.
That's why we tell the emerge, don't even talk to medicine about these patients.
Okay.
TIA out the door, and that's fine. But once they're in, we're kind of stuck, because now to discharge them, the patient's been up all night, this and that. You know what happens? We discharge them. We tell them to come in the next morning. SPC. No, I'm done. I'm not coming back to the hospital. You guys had me, and now maybe I'll come on Friday. Like it's almost compounding. Two wrongs don't make a right in that case. So I think so if they're a TIA and they're in the hospital, now we're stuck. Call the stroke consult service and
okay.
We'll put them in hospital. That's the problem.
So, but get to them before the referral to medicine, essentially.
Yeah, exactly.
Okay.
They should not be, and for the most part, I think very few. To be honest with you, some people are diagnosed with TIA, and then and it's not like many of my colleagues joke that TIA stands for temporarily incomplete assessment, right? So it's like, why? Oh yeah, TIA. So it could be that they've got symptoms. It's not really a TIA. They've got persistent symptoms that need to stay, right? That's a lot of our patients that being diagnosed as TIA, they actually have persistent symptoms, and maybe they're calling it a TIA because the CAT scan was negative. Well, if they got persistent symptoms, then probably there's a minor stroke or some other explanation.
And we see that often too in Express. We had a lady 2 weeks ago, and it was TIA. Her CT was negative, but then she was pending an MRI, and the MRI was positive. And she went to 7. So there you go.
Yeah. Oh, definitely. And Steph, you have your hand up?
Yeah, Dr. Salas, just a quick question. What proportion of patients with a stroke might have a negative CT when they first get to the ED?
Off the top of my head, a minor stroke, 30%. So like a moderate to severe stroke, you're going to see something, but a minor stroke, I would say up to a third of people will have a negative CT. There's other factors. It could be the patient has a lot of chronic microangiopathic changes, and so a new stroke can be buried in there, and you'd never really kind of see it. But yeah, it's not uncommon. Yeah.
Okay, I just wanted to highlight we're just a couple of minutes to 1 o'clock. And I did want to share that there's links for the evaluation form and to request a certificate of attendance. And also that the recording and a link to the slides will be on the website by tomorrow. So that you can access that. And I'm going to share a screen briefly to if somebody would prefer a QR code. But I do see Frank has his hand up.
Hello.
Yeah, hi, Jim. Yeah, I was just going to say hi. Frank Fornes here. I'm a hospitalist at Joseph Brand Hospital.
Awesome.
Yeah, just as you know, again, this is kind of more like for the ER guys, but I got to say, I appreciate the work that you do, and actually the very simple explanation in terms of even us helping the ER docs in terms of triaging the patient whose symptoms have resolved to make sure that they get them home. And then exactly what you said, that sometimes people get admitted with a diagnosis of TIA who have ongoing symptoms, which again is always a little bit bizarre in terms of nomenclature.
Yes.
And I did a quick search because this is my big thing. You know, how do we get the patient to you? And I just Googled stroke prevention clinic. Boom, referral form is there. Boom, easy to get. If it was fillable, I'm not sure if it is. Is it fillable? No, not yet.
Yes, the one for Joe Brandt is not, but the HHS one is actually a fillable PDF.
Yeah, no, because I mean, obviously those things are great, but honestly, great service and what you've done on the weekends, like this is fantastic. Like getting people in quickly. I'm just not sure if we are sending our patients to our own stroke prevention clinic like they are in Brantford. That's a bit concerning to me.
I think that, I mean, Joe Brandt, you have one of your internists is actually the lead on the SPC there, and she's done a good job getting things up and running. So I think the rule is, I mean, can you remind me, Steph? I think certainly a lot of patients get referred to the SPC there, and then there's a quick transfer to us, kind of like Brantford for the carotid cases. So I think the upfront is there. I think if it's a clear slam dunk, then we would probably take the ball and run with it. But there's a lot of chatter that goes on with the nurses, actually. So, you know, the team in Hamilton and the team in Brantford discuss the referral. And then, so likewise, the team in Burlington and the team in Hamilton, as soon as there's a referral, they cross-reference and say, okay, well, this patient was referred to us, but it sounds as though it's like should we just run with it? It looks like a straightforward carotid case. So there's a lot of communication between the stroke prevention clinics. Sometimes we get referred patients from Burlington that are not carotid cases, and so those do go just in terms of like dividing up the work, those do go to Joe Brandt first. I think that we have like honestly a dozen neurologists seeing patients, so that's the thing. I don't know how many people are seeing patients in Joe Brandt, but I think that the wait lines are not too long for SPC. Oh, just the one? Okay. Oh,
You're on mute, Frank.
Okay.
Oh, here we go. Okay. You know, I think that there's the gym rat clinic does it. So there's actually somebody every day, kind of like you, like every work day, there's somebody there, but just not on weekends and holidays.
Okay.
Okay.
Yeah, and I think the gym rack is separate from the stroke prevention clinic there, right? I think that maybe if they go to the same place, they channel them to the SPC.
They do. I think it's the same people. Yeah, Gurpreet runs it. She's fantastic, right? But
yeah,
I think that she can't be there every day. So it's like the gym rack physicians kind of take a turn, kind of going through her algorithm with these patients to make sure they get taken care of quickly.
Yeah. And then Claudia, I see that the inpatient team consults HGH neuro for these patients. They don't go to local SPC. So yeah, I think the ER, yeah, we just need to kind of review the ER pathway and then go from there. Yeah, that'd be great, Claudia.
Okay. Well, thank you very much, Dr. Salas. It's 1:01, and I know people do need to get back. So want to thank everyone for their engagement. We do have our next stroke series for Hospitalist presentation on November 21st. And Dr. Shrivastava will be speaking on navigating antithrombotics in stroke management. And it's the same Zoom link or Zoom ID at noon on November 21st. So hope everyone has a great rest of the afternoon. Bye.
Thanks, bye.
Thanks, Dr. Salas.
Welcome.
Thanks, Dr. Salas.